Hello, everyone, and welcome to this edition of Aftd's Healthcare Professional Educational Webinar Series, Maximizing Communication, Maintaining Connection, Person-Centered Care for Primary Progressive Aphasia. My name is Esther Kane, Aftd's Support and Education Director. On behalf of everyone here, thank you for joining us. We are going to begin the webinar in a couple minutes. But first, I'd like to share a few housekeeping items and Aftd information for you. Please note that our audience will be muted for the duration of this webinar. This helps to keep the background noise to a minimum so that everyone can hear the presenter clearly. If you have any technical issues, please write a message in the questions box, and we will try to address them with you. There should be time for Q&A at the end of the presentation. If you have a question for one of our presenters, type it into the questions box when you think of it. You don't need to wait until the end of the presentation to submit your questions. In fact, we prefer if you ask them as we go. Additionally, this webinar will be recorded and archived for later viewing on both Aftd's YouTube page. I have some updates from Aftd. First, I highly encourage you to visit our website at theaftd.org. Our website includes regularly updated and professionally vetted information about all the FTD disorders, including a special section devoted entirely to PPA and its subtypes. If you are seeking information about PPA, our website should be your first stop. Next, I want to make sure everyone is aware that our next education conference will be held May 5th in downtown St. Louis, Missouri. This annual event convenes persons affected by FTD, experts in the field, and other healthcare professionals for a full day full of learning and connection. If you can't make it to St. Louis, don't worry. You will still be able to watch along with others in our free live stream. We will provide much more information about our conference in the months to come, but for now, be sure to save the date. We hope to see you there. We hope you turn to Aftd as your top source of information about all forms of FTD. Here are some ways you can stay connected with us. If you are treating someone with FTD and have any specific questions, we encourage you to email or call the Aftd helpline. Trained professionals will be happy to provide the information you need. Finally, we encourage you to sign up for Aftd's newsletters to get the latest developments in the world of FTD. You can scan the QR code on screen for more information. One of Aftd's newsletters is specially geared towards healthcare professionals. Each issue of our Partners in FTD Care takes a deep dive into a particular disorder or specific aspect of care. Recent issues have focused on transitioning to residential care, FTD genetics, and the unique challenges involved in providing dementia care to a younger person. There are over 30 issues of Partners in FTD Care available by accessing the web address at the bottom of your screen. Some more information about today's program. We are offering continuing education credits via Rush University for those watching this webinar live. This is part of Aftd's developing efforts to educate healthcare professionals on FTD and FTD care. At the conclusion of the program, you will receive an email with the CEC submission information. Please note you have 10 days from the date of the activity to complete the evaluation and claim credit. At the conclusion of the webinar, you should be able to list at least 2 symptoms common to PPA, recognize 3 practical ways these symptoms impact communication between a person with PPA and a caregiver, describe 3 effective person and family-centered approaches to maximize communication and minimize frustration. Additionally, there are materials related to this program located on the handouts box on your screen, along with information about Rush University CEC approval for this program. Now we're going to ask you a poll question. I'd like to ask you to answer this question. Have you ever supported or cared for someone with a PPA diagnosis? I'll give you a few seconds to weigh in. Right. So some of you have cared for one person, some of you a few, and some of you many. And about a quarter of you haven't cared for anyone. So we have a real mix of people attending today. And I think all of you will learn something valuable with our presenters. Now I'd like to introduce you to today's presenters. Darby Moreheart, PhD, Lcsw, is professor in the Museum Center for Cognitive Neurology and Alzheimer's Disease and Department of Preventative Medicine at the Northwestern University Feinberg School of Medicine. She is director of the center's Outreach, Recruitment, and Community Engagement Core, Quality of Life programs, as well as clinical social work services for both the center and the Northwestern Medicine, Neurobehavior, and Memory Clinic. She is currently piloting the adoption of an evidence-based caregiver intervention for family caregivers of persons living with PPA. Emily Rogalski, PhD, is the Ann Adelman Perkins and John S. Perkins Professor of Alzheimer's Disease Prevention at Northwestern University's Feinberg School of Medicine. Her PPA research focuses on characterizing the clinical and anatomical features of PPA, drivers of disease progression, identifying risk factors, and refining our understanding of language network organization. She has also pioneered a line of intervention research concentrated on maximizing care and quality of life for individuals living with PPA. Please join me in welcoming our presenters.
Emily, could you unmute, please?
Hello, everyone. Just one second. Let me click to the right screen. All right. Hi and welcome. I'm so glad to be here to talk to you about a topic that is near and dear to my heart. So PPA research and finding opportunities to maximize communication and maintain connection. I'm delighted to be here with my colleague, Dr. Moreheart, and so we can walk you through some of the ways that we think about these aspects. And by way of introduction, I wanted to tell you a little bit about where we are, where we're coming from, our setting. So we are located in the Mesulum Center for Cognitive Neurology and Alzheimer's Disease, which is a mouthful, but means that we do aging and dementia research. Here at Northwestern University. Our goal at the center is to conduct research on the neurobiology of brain aging and Alzheimer's and related dementias, including primary progressive aphasia, to develop personalized diagnostic, clinical care, and intervention modalities, to train the clinicians and scientists of the future. And we do this in a really special way. We're a multi-departmental unit, meaning that we don't, we're all together in the same space, social workers, neurologists, neuropsychologists, neuroscientists, coming together to do this research and design interventions and to train the next generation of scientists so that we can think about the neurobiology of disease from under the microscope, from imaging perspectives. We can also think at the same time about how these disorders disrupt one's personal identity and how the changes happen in family and life dynamics. And then what are the different and distinct cognitive profiles of each of these individuals? So now I want to kind of center our thoughts back to this term primary progressive aphasia. A lot of the terminology in the dementia literature is often very confusing. Primary progressive aphasia, when Dr. Mesulum defined this disorder back in the early 1980s, it was he did a great job of building the definition right into the moniker. So aphasia, it refers to a language impairment, and then it's progressive because the impairment's going to get worse over time since it's caused by a neurodegenerative disease. And it's primary, the word primary comes into play because it's prominent in a single domain language with relative sparing of other domains early on. So memory, personality, judgment, those aspects are relatively preserved early on. Okay, Another question that commonly comes up is it PPA or is it dementia? And how does PPA, the term primary progressive aphasia, relate to the term dementia? So dementia is a clinical term for the loss of memory or other thinking skills that is so prominent that it significantly interferes with one's daily life activities. So here we're really talking about the change that occurs from one's former self. So it's interfering with work, school, or family life. And so there are different causes to dementia. Some of them fall into categories that we think of being potentially reversible. So there are can be vitamin deficiencies that happen, medication side effects, other medical conditions, or excessive alcohol use that can cause changes in our memory or other thinking abilities. And once these are addressed, those symptoms go away. The category of neurodegenerative diseases is a category where primary progressive aphasia falls. It's this is where there are changes that are happening within the brain, the accumulation of bad proteins that are happening that cause the symptoms. And when we think about dementia syndromes, there are more than one dementia. There's more than one type of dementia syndrome. So the big umbrella term is that is the word dementia or clinical neurodegenerative dementia syndromes. And then underneath that umbrella are the different types of dementia syndromes. So Alzheimer's dementia being the most common one, where there's memory loss, that's the primary deficit. And then I put a few other examples up here, including posterior cortical atrophy syndrome and behavioral variant frontotemporal dementia. And then finally, today's focus, which is on primary progressive aphasia. So how is that diagnosis of PPA made? It's made in part from taking this process of ruling in and ruling out. So there needs to be a comprehensive medical history, both from the individual experiencing these symptoms and potentially their family members. There's a neurological exam that takes place. A neuropsychological assessment by a specialist is often another component, and then laboratory measures. So these laboratory measures could be blood tests. They could be imaging scans of the brain, such as MRI scans or PET scans, to help make that diagnosis. Now, the diagnosis of PPA is very difficult and is less well known. So the diagnostic journey for PPA can often take months, months to years. And unfortunately, it has tended to fall on the years side of the coin. And so there's a real opportunity and need for increased awareness and efficiency. We've seen some increase in awareness over the last 5 to 10 years, but there's still room for more growth in this space. And while both Dr. Moreheart and I have some expertise in the syndrome, really the people who have the most expertise, of course, are those who are have the lived experience. And so I wanted to share with you a couple of videos of individuals who have been living with PPA, and so you could hear from their perspective.
Originally, I had trouble with my jaw, and for about 3 years, I was working with different appliances and things like that, and to think why my words weren't coming out right, and I could feel that this was not a mechanical thing. This was inside of my head, and it just felt like it was mechanical, and it just got to the point where it just was horrible. I mean, I was afraid I was going to lose my job. I think I Googled what happens when your brain doesn't speak anymore, and then it came up aphasia, and then from there, and went out of it like a pit bull, and then made things happen. She made a lot of things happen very quickly.
I also had noticed, and it's almost like just a very slow event unfolding over time. You make micro adjustments along the way in your life and your lifestyle. for these sort of small declining abilities. I noticed that Steve was getting more and more fatigued, and I wrote it off as normal aging. He did show me the definition of aphasia. I didn't give it any serious consideration at all. I was reluctant to I didn't see it. I just didn't see it, and it was right in front of me the entire time.
So when we think about the diagnosis of PPA, it's not generally the first thing that comes to mind, because often people have never heard the term primary progressive aphasia. And the symptoms that emerge often happen in individuals' lives when they're in their 50s and 60s, not 70s or 80s. So the term dementia or progressive disease is not the first thing that comes to mind. And then it's often potentially attributed to other causes, whether it's anxiety or depression. And so that can add to that diagnostic journey.
Originally,
we were working on conference calls, and as more and more people were on the calls, I was getting lost, and it wasn't good.
He was realizing it was hard for him to communicate at work, and he had been leading conference calls, and those were getting more and more challenging. And I could tell just something was wrong as it was progressing and getting worse. And so we knew we had to figure it out. So we just searched, went to lots of doctors till we got an answer. We went to 3 different states, 7 different doctors.
So you can hear that the journey can be long. If we move back to thinking about what have we summarized so far, so there's the clinical symptoms, a progressive aphasia with relative sparing of other thinking abilities. Why does this happen? It happens because the diseases are targeting a region of the brain that are important for language, and so those regions are highlighted here. And then the disease, what is the disease that's causing PPA? If things were simple, there would be a PPA disease that causes primary progressive aphasia. Unfortunately, things are far from simple, and instead there are 3 families of neuropathologies that can cause PPA. So primary progressive aphasia can be caused by Alzheimer's disease neuropathology. Alzheimer's disease neuropathology is defined by amyloid plaques and neurofibrillary tangles. It can also be called by a family of frontotemporal lobar degeneration pathology called FTLD tau, or a third family called FTLD TDP43. And what has been challenging up until now is that it's been difficult in the living individual to identify which disease is present at the individual level. This is changing now because there are in vivo biomarkers that are emerging, both in the form of using CSF from a lumbar puncture, PET imaging, and now even emerging blood tests that might be helpful in distinguishing among the neuropathologies. These are most mature in the Alzheimer's disease space, and we hope there will be future development for the other 2 families of diseases that cause PPA. When we think about primary progressive aphasia, it's not just the impact on the individual, it's the impact on the whole family. And when you've met one person with primary progressive aphasia, you've met one person, because there's a lot of variability. There's variability in the initial language symptoms. These have now been grouped into 3 broad subtypes or subcategories of deficits. One of them is called the semantic variant of primary progressive aphasia, and that's characterized by preserved grammar but impaired word comprehension. There's an agrammatic form of PPA that's characterized by impaired grammar and preserved word comprehension. There's a logopenic form of PPA, which is characterized by preserved grammar, preserved word comprehension, but impaired word finding or retrieval, and potentially impaired repetition. Now, as individuals, we don't all neatly fit into these buckets, and so the deficits for some may align very neatly early on, but for others, there may be a mixture of these deficits. So it's okay. Having a particular subtype or aligning specifically with that is not the goal. Instead, the goal is to better understand one's strengths and challenges, and to understand that there's going to be change that occurs over time. So the variability in the emergence of new symptoms is quite large, with some individuals who may experience memory loss or changes in judgment and personality as the disease progresses. There's variability in that rate of decline, where some individuals will decline relatively rapidly, and you'll see severe impairment in as short as 2 years, while others have reported living and functioning quite well for about 20 years, up to 20 years. So that life expectancy range has also got variability. And then variability in the impacts on your daily life, relationships, and one's independence. When we think about how do you care for someone with PPA, the first group of individuals that come to mind are your care team, building your care team, and that includes your family members, but also might include a speech-language pathologist, a neuropsychologist, a neurologist, and a social worker. But the care team and the building of that care team doesn't end there. There are many other individuals who may be involved in the care of someone with PPA and can be helpful. And some of those care partners are more relevant at different phases or points in the syndrome, depending on the symptoms that one individual experiences and where they're transitioning to in and out of care. When we think about treatments, currently there's no cure, but this is an active area of research. There are medications that may help with particular symptoms, for example, the experience of depression, anxiety, or trouble with sleep. Those who have the form of PPA that's caused by Alzheimer's disease neuropathology, it may be appropriate to then use Alzheimer's medications for those individuals. Now, to think about other aspects of intervention and treatment, the non-pharmacological aspects of treatment. Non-pharmacological interventions can come in many shapes and sizes, including art therapy, music therapy, support groups, and speech-language therapy. The most common that we hear about are support groups and speech-language therapy. So I'll touch briefly on the support group aspect, and I think Dr. Moreheart will also pick up on this as well, and then spend the rest of the time on some of the interventions and styles that we have used in speech-language therapy. So support group models, there's been a variety of models that have been proposed and successful for those with PPA, and we've used them both here at the center and elsewhere. They have been led. So there's traditional support groups, there's been educational groups, activity groups, and online groups. And here we're showing you an example of some of the artwork that was developed as a part of one of our support groups that both combined a traditional support group with education and activity. Over here on the right is an online support group that we started years ago as a trial, which seems a little bit more commonplace now that we've lived through COVID and the pandemic. But at the time, there hadn't been many groups of this kind. And so it created an opportunity for both education and connection, and we had the dyad that came to the support group, and they came together for the educational portion and then split apart for two separate support groups, one for those who are the care partners, and then followed by another one for individuals with PPA. Some of the themes that came out of that group included coping with limitations of language decline, a sense of belonging, confronting stigma, and expressing resilience. And if you're looking for support groups, we offer them at our center, but there's a comprehensive list that you can find through the Aftd, and so I encourage you to look there. So the next thing I'll transition to is thinking about non-pharmacological interventions in the form of speech therapy. And so non-pharmacological interventions, including speech language and psychosocial intervention, may offer significant benefit to the quality of life and care of those with individuals living with PPA. But they've really historically lacked efficacy evidence and guidance on direct care, on best practices of care. We've been trying to change this landscape, and one way we've been doing it is through the Communication Bridge study, where we're really focused here on maximizing communication participation and quality of life and minimizing burdens for individuals with PPA and their families. So we've led a series of pilot trials that have been telehealth in nature so that we can bridge the gap of reaching individuals no matter where they live. And it's been supported by a custom web application and this person-centered approach that I'll talk about next. We also use a dyadic approach, so it is both for the individual with PPA and their care partner. Success in this intervention and these types of interventions is measured by the person's ability to engage in everyday activities, personally meaningful activities, and maximize their quality of life. So when we think about checking in with an individual, trying to support them in their daily lives, this is a process that needs to be iterative. It's iterative because there's changes. It's a progressive disease. It's collaborative because you're seeking input from the individual, from their family members and other care partners, or in an assisted living setting, others who are interacting with them. It's dynamic to the individual, and then this allows for setting of unique goals, designing personalized strategies, and communication interventions and strategies. So questions that you might ask include independence. What can the individual still do or potentially do independently? And what could they do if they had a bit more support in certain spaces? Personal identity. What's important to that individual? What provides purpose and motivation? Knowledge and insight. What is the individual's understanding of their disease, its progression, and their own strengths and limitations right now? And what's the understanding of their care partners' knowledge in those spaces? Viewpoints. So consideration of input from multiple stakeholders, the individuals with PPA, their friends, their family, and clinicians. What are those clinician reports saying? Expectations. What are their expectations, and how do those expectations align with where they are today? And then environmental supports. What are the communication environments that they're most regularly in, and which ones do they want to be in? So we think about three overall approaches. So we want to have personalized communication strategies, communication partner training, and then think about ways that we can modify the environment so that it maximizes the opportunity for communication. When we think about those language and communication strategies, the first thing that often comes to mind, again, we want to be dynamic, tailored, and multi-component here, not just thinking about one way of addressing these challenges. So anomia, or the difficulty thinking of words in conversation, is a nearly universal description of areas of challenge for those living with PPA. And so one thing that might be that we use here is the identification of meaningful words. So it's not just about the retraining of words in general, but really getting at which words are most important to them and are interfering with their ability to live in their daily life. If you're a speech language pathologist, you may use a multi-level mixed phonologic semantic word retrieval cueing hierarchy to practice with the individual with PPA. And so this could look something like the ones here on the right, where you have a personally meaningful image of perhaps the flowers in someone's garden, or their grandson, someone that's important to them, and then developing this hierarchy to practice. This has been an approach that has evidence-based and shown to be helpful in PPA. In fact, the most evidence for intervention in PPA has been in this space of word retrieval. This can be supported by asynchronous independent home practice. So individuals can make flashcards. These could be paper-based flashcards. They could be digital flashcards. If someone is really adept at using technology, there are many apps like Quizlet and others that allow you to make these aids or flashcard style exercise that can support these activities. Multimodal communication support. So there's more than one way to support an individual with PPA. There might be paper-based aids that you place around the home or that you take with you for portable use. These can include aids like I've shown here, where someone may have the ingredients for their favorite salad. And so they may have this close by to them in the home to allow for it to be easier to create that salad. This could also serve as a shopping list that someone takes with them to the grocery store so they remember to buy the right ingredients, and having both the picture and the word written below that picture can help them find and identify those items in the aisle. I wanted to share a success story from one of our Communication Bridge participants. This man, he was a sheep herder as part of his daily life, and he was having difficulty remembering the commands that he needed to give his dog Cookie in order to herd those sheep. And through the process of practicing the commands in this way, he was able to regain those words and regain this activity, which was incredibly meaningful to him. The last and then, of course, there can also be communication partner training. When someone loses language, it's not just a change in communication for that individual. There's also a change in communication and style that might be needed for that the care partner needs to learn, so they can learn new strategies for helping to support the individual. This can include coming up with non-stigmatizing cues so the individual is able to let their care partner know when they want help. It's having a conversation to see whether the individual with PPA wants their care partner or supportive partner to fill in the word when they can't think of it in the moment. Okay. Another way we think about supporting individuals with PPA is through communication strategies, helping individuals build skills to align communication with whomever they're talking to, their friends, their family members, and others. And identifying, so here we want to identify the types of conversations and barriers to those conversations. Does the individual have the most difficulty with one-on-one conversations, with conversations in large groups? Is it in planned or versus unplanned life situations? So we can develop aids and scripts for helping to make it more automatic in some of these activities, like answering the phone. You could keep a script next to your phone, or you could practice answering the phone and making an appointment. There might be event-specific activities that an individual might want to practice, use script practice for. That could include wedding speeches, holiday interactions, and focusing then again, is this in an individual setting or a group setting? And so over here, I've given 2 examples of scripts that have been worked on with individuals with PPA. And so this is the individual's favorite fast food order. And then this is a card that an individual with primary progressive aphasia, they took the basic language that we had that explained the condition, and they made it their own. I have primary progressive aphasia. This is caused by a condition in the brain that makes it difficult for me to say the words I need to say. Sometimes I may also have difficulty understanding what others are saying to me. I'm not under the influence of alcohol or drugs. There is nothing wrong with my hearing, memory, or thinking abilities. How can you help? Give me time to communicate. Speak simply and directly to me. Do not shout. It does not help. Ask yes, no questions. Write down keywords. So these are really valuable pieces of advice that we hear from other individuals with PPA, and this individual was able to customize their card and keep this in their wallet so they could use it when they came into interactions that might be helpful to share it with a waiter, for example, or a cab driver or a clinician. So then there's a possibility of practicing these scripts with a clinician or practicing them at home. There may be other supportive paper-based or digital aids that an individual wants to use in this environment. And then finally, thinking about environmental considerations. There may be ways to foster success by, if you're going out to eat, asking to sit in the corner away from the middle of the restaurant that might be noisier. If you're going to an outing, is there space where an individual can have some time to take a break? What time of day is best for the individual? Are they best in the morning? Should you avoid activities that occur in the evening? These are all things that you can identify through this dynamic assessment and make plans that align with the individual's wishes. So at this point, I'm going to transition it over to Dr. Moreheart.
Thank you, Dr. Rogalski. And hello, everyone. It is a pleasure to be here, and I really appreciate the invitation from Aftd to join you today. I wanted to start out by briefly reinforcing this notion of the heterogeneity of dementia. In our center, we developed what we call this care pathway approach to understanding symptom presentation or neurocognitive profiles. As we know, a more typical presentation of Alzheimer's is memory loss. Behavioral variant FTD is emotional and behavior changes, and Lewy body dementia and posterior cortical atrophy can be the visual variant of Alzheimer's disease, and these are visual spatial changes. And then, of course, primary progressive aphasia presents with language as the primary symptom initially. In PPA, the language continues to decline over time and are initially the only cause of limitations to the person's activities of daily living. In addition to identifying the disease symptoms and disease stage, it is important to understand the age of onset for persons living with PPA, as Dr. Rogalski mentioned, are generally below the age of 65. So the family experience is unique to that life cycle stage, which is very different developmentally than those in an older cohort. Another area to consider are the psychosocial factors of the family and their support network, and also the socioeconomic factors such as access to care and resources. So the differences in all of these areas mean the differences in the way you treat, understand, and educate families living with PPA. So one size does not fit all. Next slide, please. So in my clinical practice, I find it helpful to conceptualize PPA within a similar framework as other neurodegenerative disorders, which are thought of as progressing in the clinical phases with respect to global functions, such as the asymptomatic or preclinical, mildly symptomatic or mild cognitive impairment, and then dementia. So ultimately, in PPA, other cognitive and motor difficulties do develop, and strategies to help the person and family need to also be part of the clinician's toolbox. Next slide, please. So as Dr. Rogalski indicated, the pathway to getting a diagnosis of PPA is very circuitous and lengthy. There can be a gradual onset of symptoms, as you saw in the videos, and the changes are very difficult to pinpoint. So we know that dementia often persists and worsens over years, and John Rowland is a psychiatrist in Chicago who has long studied chronic illnesses in families. And his 2017 paper outlines his family systems illness model as a guiding framework to this ongoing evolving process that families experience with neurodegenerative disease. And he describes an initial crisis phase, which includes any symptomatic period before the diagnosis and the initial period of readjustment and coping after the diagnosis. So on average, there can be 2 to 5 year interval between symptom onset and the medical evaluation for many reasons that include confusion about what's bringing on those language changes. But the tasks of the family are to pull together and establish working relationships with the healthcare team, but also to grieve the loss of the life before the illness and figure out how they're going to live with this. And we as clinicians have a lot of influence at this stage. Although the healthcare provider disclosure rate for a diagnosis of cancer or cardiovascular disease is over 90%, it is still below 50% for neurodegenerative dementias. It's really essential to communicate a diagnosis to patients and families so they can begin to plan for the future. I like the way Dr. Rollin talks about the diagnosis and being and educating a family provides a framework or a supportive base for the patient and family to live with this over the long haul. Next slide, please. Thank you. So you get the diagnosis of PPA, and the challenge is now living with it over time. So in the chronic phase, families are coming to grip with the long-term changes, such as not only the declining language, but also difficulty planning and organizing the day, to the point also where there's also need for assistance with personal care. And caregivers struggle with these changing roles and how to best communicate with their person and how to understand what their person can still do and where they as a caregiver need to assist. And this is where we as clinicians can help caregiving families by continuing to provide ongoing education, counseling, support, and continuing to recognize remaining strengths and also normalizing the feelings of loss. It's also during this phase that we need to be alert to a family caregiver's exhaustion. We may want to help them engage other family members to understand how and if responsibilities can be shifted and or bring on more formal care supports. Next slide, please. So Pauline Boss is a scientist and clinician who coined this term or phrase, ambiguous loss, in 1970. It's the type of loss you feel when a person is physically there, but may not mentally or emotionally present in the same way as before. This is very different from when someone dies and you clearly know that the person's gone and where you are more likely to get support from family and friends. And you may eventually find closure through traditional mourning rituals and natural grieving process. So this ambiguous loss complicates how families grieve. It can be hard to recognize this grief and or know how to grieve when the person's abilities are changing. It also confuses relationships and it can prevent people from moving on. For example, a spouse may feel they're no longer in the same kind of marital relationship if they cannot communicate in the same way and they see their person becoming more dependent on them. So helping families recognize these feelings and helping them understand the concept of this ambiguous loss can help to ease those effects. And perhaps with that guidance and support, they can work through these feelings and begin to grieve the losses and stay connected to the person with PPA while also building on their own strength and resilience. Next slide. So this slide encapsulates all the challenges for persons living with PPA, which we have been describing, such as difficulty getting a diagnosis and ambiguous loss. I'm going to talk about a few more on the next slide. So let's talk a bit about complex family dynamics that you may run into. The psychological, social, family, and financial issues that affect individuals with PPA are very unique. As we've been saying, not only the patient is younger, his entire family is younger. Young children may still be living at home or going off to college or trying to leave home. The person with PPA has to stop working at a time when they're probably in the prime of their working career. And also they're saving for retirement and supporting their younger family. And because of this loss of employment, the well spouse may need to seek additional work to meet the family's needs. Next slide, please. So financial concerns are abundant. It is difficult to perform job tasks when it's difficult to carry on conversations, think of names, speak articulately about areas in which one was typically very well versed. There can be very often misunderstandings by employers and coworkers. And then persons with associated personality or behavior challenges or changes may engage in poor financial management and make inappropriate financial decisions. So these are individuals that are at risk in performing at their job, and with that can bring a loss of self-esteem, a feeling of not being able to be productive, and they may be terminated from their positions before the illness is understood. A loss of income also impacts the affordability of future long-term care. Many have not saved enough yet at that younger age and may also have young children they're supporting. And after a diagnosis is made, it's too late to obtain long-term care insurance. Next slide, please. So historically, persons with young onset dementia of any kind, PPA and other forms of FTD have had very grueling and lengthy Social Security disability insurance application processes, usually with multiple denials and appeals. And they really, I do run into this, I still run into this today, but there is a compassionate allowances program that the Social Security Administration rolled out, and they allow for benefits to be quickly provided to people whose medical conditions are so serious that their conditions obviously meet disability standards. And so, due to the successful advocacy efforts by the AFTD in 2009, FTD was one of the first 50 conditions named in the Social Security Administration's Compassionate Allowances list. And then PPA was one of the 38 conditions subsequently added in 2010. Next slide, please. So as clinicians, we are helping families live with PPA as it progresses over time, supporting their caregiving role, validating their feelings of grief and loss, while also helping them maintain connection with their person and helping them build new connections. Next slide. However, caregivers cannot do this without tending to their own self-care. And part of that, self-care, as you can see in this diagram, is just getting enough sleep and eating well and exercising. But also, as Dr. Rogalski was talking about before, getting that team together and hiring more help, finding a support group. In the next slide, I just want to show that we have been offering 3 online care partner support groups. Oh, you can go back. And we were offering these pre-pandemic and then moved everything online. And due to the increased accessibility of online support groups, our PPA caregiver group has quadrupled in size to where we now hold 4 concurrent groups: early, moderate. It's usually a 1 early group, moderate, and advanced. And we have representation from 10 states throughout the United States. And those meet monthly. And you can see that there's some quotes here from families who are participating in these groups and how supportive they are to them. And in my final slide, in our efforts to offer tailored caregiver interventions that are also accessible to patients and families in our center, and thanks to a pilot grant from Emory's Roybal Center, we adapted Telesavvy and piloted PPA Telesavvy with caregivers of persons living with PPA. And the revisions to this evidence-based program were informed by former PPA caregivers who participated in the regular Telesavvy version. And as one person said, I felt like Telesavvy was upside down. Alzheimer patients lose their language later in the game, whereas with PPA, you've got to start with language loss. And then the next couple of slides, I just wanted to share with you. These are a bit old now, but I think very relevant articles. One from the Chicago Tribune, When Words Fall Away. This was an interview with one of our patients and families. And then the next one is A Thief That Robs the Brain of Language by Jane Brody for the New York Times. And you have the links there if you'd like to look them up. And with that, I want to thank this wonderful team that I work with every day, including Dr. Rogalski, Dr. Mesulem, Weintraub, and so many others that we work with on a daily basis, and also especially our persons living with primary progressive aphasia and their families.
Thank you so much, Dr. Moreheart and Dr. Rogalski. My mind is even spinning right now with things that I know that I want to look at and go back to and rewatch in this particular presentation. We have a quick poll we're going to ask again here, and I'm going to share my screen. Okay, wonderful. Let me get my screen up here. Well, it's not letting me share my last screen here. Oh no. Matt, can you make me the presenter again in the background there? In the meanwhile, we have a few questions that maybe you guys can help us with answering. So Dr. Rogalski, there were some questions about the assessment tools that you use, and they were just wondering, are there specific tools that you're using for SLPs in the assessment with PPA?
That's a great question. So I think it's possible that you can design this interview however it works best for you. We have found that using a modified version of the assessment for living with aphasia has been really useful for kind of designing and asking these questions in a standardized ways. There's a few adaptations that we had to make because that tool was developed for individuals with stroke-based aphasia. And so the outcomes there are a little bit different. We're not dealing with a progressive syndrome. And so some of the questions needed to be sort of revised and tweaked. When we're thinking about the modes of communication that individuals use, we used a portion of the social networks inventory. So thinking about the different modes of communication one might use, whether it's gestures or AAC or how do you communicate, and then how is that going? That helped to structure some of the questions that we asked. And then finally, using a goal attainment scale process for setting goals that were personally meaningful and thinking about what those levels might be of improvement or change, but not making those dependent on whether aids or supportive tools would be needed.
We had somebody else ask if sign language can be used, and if you've had any experience with trying to incorporate sign language.
There have been some historical reports of individuals trying to learn sign language. And then on the flip side, though, there have been reports more commonly that because it's affecting the language network, that those have been less effective. So the use of gestures tends to be more useful than trying to layer on the new learning of a whole nother language, with sign language being that new language.
Dr. Moreheart, looking at the results of our poll, 61% of people actually said that impaired communication needs was the biggest challenge that people with PPA face. Would you agree that that's one of the biggest challenges people face, or do you think there's other things we should be considering?
Oh, it's essential. I mean, this is really the key impairment in primary progressive aphasia. So I think I would agree with the audience here in that language and that loss of ability to communicate in the same way that you were able to communicate before with your spouse, your parent. You are, as a family member, challenged to make some shifts in the way you communicate. And it can be easier for some than others. And I think that's why we need to really get to know families and understand their history, their historical relationships, and all of that impacts and complicates, how they cope with this over time.
But I think there is a lot of hope, and there's opportunity to kind of maximize that communication as best we can, and really thinking about what are those challenges. People were uninvited, they didn't invite this disease into their life, and so you have people who become care partners who didn't train for this and didn't ask for this, and so it really is taking that time to understand those relationships and where those challenges are, but finding ways that work specifically for them to maintain connection.
As you guys have worked with families and as they've kind of figured out ways to communicate, even though language is going, how has that affected people's moods? I'm sure you guys have some stories of how it brought a little hope to know that they may be able to find some connection. So can you speak to that as being, helpful?
Yeah, I think we've seen this be really powerful. We've seen people who have abandoned entire activities, whether that was golfing with friends because they were embarrassed or they hadn't shared their diagnosis yet and they didn't know how to approach this, to stopping going to family events like Thanksgiving, to being able to read in front of the scripture in front of church if that's really meaningful to them. People have re-picked up books because they found a new way to interact by using maybe digital books that allow for you to tap on words that give you definitions if they're having trouble remembering the definitions of those words. So I'm sure Darby has some other success stories.
I'm thinking of a recent couple who their daughter got married, and he ended up the speech therapist worked with him on a toast for his daughter's wedding. And, they revised it to just make it just exactly right so that he was able to be most successful when delivering that toast at that wedding.
I think that is a great way to close out this presentation as the tears start streaming down the side of my face. I think if we learned anything today, the biggest thing to take is that we need to make sure we're caring for the whole person and taking into consideration all of their needs, and doing our best to kind of supplement where we can and support where we can as clinicians. So thank you so much today for coming and presenting and sharing your wealth of knowledge to us all. I'm sure this video will be shared often after this presentation. Before we leave, though, I just have a few things I want to add. As Dr. Moreheart and Dr. Rogowski talked about, there are many studies happening right now in the FTD space. And we want to make sure that people are aware of what is available and how they can engage with research right now. So there's a lot going on, and we really want to encourage people to take advantage of the opportunities that are available where they feel like it's appropriate. Many FTD clinical studies and trials are underway seeking participants, and studies can include experimental treatments to target FTD symptoms, as well as potential disease-modifying treatments for people with sporadic and familial FTD. Studies also include naturalistic observational studies to map the cause of the disease. So how can people living with FTD learn more about these research opportunities? The best way to encourage your patients to get involved is to have them sign up at the Ftd Disorders Registry by visiting ftdregistry.org. The registry provides one location to learn about research participation opportunities and share their stories to inform research design. Participants' personal information is never shared. You can also sign up for AFTD's newsletters at theaft.org to stay informed and emerging research opportunities and the progress being made in existing studies. The next webinar in the AFTD Healthcare Professional Education webinar series will be held in November, so please keep your eyes out and sign up for our newsletters so you'll be notified when it becomes available. Thank you for joining us, and thanks again to Dr. Rogowski and Dr. Moreheart for their informative presentation. Thanks also to Rush University for allowing us to offer continuing education credits for this webinar. If you have any additional questions or comments about today's presentation, please reach out to us. We would love to hear from you. Thank you.